is an interesting topic and quite a new entity in terms of the diagnostic definitions. So it'll hopefully be an interesting presentation. My references are Scott Brown, 8th edition, and a systematic review from 2018, and a review by Dr. Staab, who in 2017 was the guy that actually founded the diagnostic definitions of PPPD. So to jump right into it, PPPD is a chronic disorder that sort of fits within the category of functional dizziness disorders. It can arise as a complication of quite a wide range of precipitating events, vestibular and generalized medical conditions and psychiatric conditions and psychological stresses. And instead of a healthy adaptation response that results in recovery of the symptoms, the patients with PPPD undergo a maladaptation, resulting in abnormal integration of sensory inputs and abnormal interpretation of spatial orientation and threat assessment that basically gets into a vicious cycle, similar in many ways to the pathogenesis of tinnitus, resulting in a conditioned anxiety response. And it's the anxiety that drives the chronicity and the patient's functional disability. It's a disorder that is seen basically almost entirely in adults. It's not really seen in children, but adults of any age. Women are slightly more affected than men. It's a common disorder. It's probably one of the most common disorders seen, certainly in our Grooterskuur Dizzy Clinic. And it's important in that about 10% of patients with chronic dizziness become functionally disabled. So it's an important thing to be understanding. If we look at the previous definitions that led up to the evolution of PPPD, first of all, it fits, like I said, in the classification of functional dizziness disorders. And as far back as 1986, there was a description of phobic postural vertigo, which basically followed any organic vestibular disorder and stress and resulted in positional vertigo or dizziness, anxiety, obsessive compulsive personality disorder traits, and mild phobic symptoms. In 1993, space and motion disorder was described. That it's still controversial, as you can see from this table. It's controversial as to whether it's a complex of symptoms or an actual diagnosis on its own. But in any case, it's now obsolete. But that basically unified the diagnoses of street neurosis, space phobia, and motorist vestibular disorientation syndrome. Then in 1995, there was a description of visual vertigo that was basically, it occurred in patients who had otherwise recovered from acute vestibular disorders, but just complained of dizziness in specific situations with complex or moving visual stimuli. Then in 2007 was the precursor to PPPD, which was chronic subjective dizziness, which won't go into too much detail because that has now been superseded by this PPPD definition from 2017. So its definition is accepted by the International Classification of Vestibular Disorders in 2017, and also in the upcoming ICD-11 diagnostic criteria. Although some of the details and aspects of the details are still being figured out, that's where it's at. And as with many other functional disorders, the etiology, the clinical presentation, and the prognosis are all quite heterogeneous. So then if we look at the etiology, there's various models to try and explain hypotheses to understand why some people with these stressors get a maladaptation sort of response as opposed to a normal response. And if we start with a neurophysiological model, first of all, in rats, it's been shown that vestibular deafferentation causes anxiety-related behavior, and treating the rats with SSRIs actually relieves that behavior. So clearly the central pathways for vestibular function and anxiety and mood are closely related. In human neurophysiology, the parabrachial nucleus is important. It's got connections to the vestibular nuclei for vestibular function. It's got connections to the amygdala and limbic cortex for the experience of pain and anxiety responses, and connections to the hypothalamus for autonomic symptoms of the stress response, and connections to the hippocampus for memory of what stimulus actually caused this response, which is then important for subsequent exposures to those situations. If we look at a neurochemical model, the monoamines, which include serotonin, noradrenaline, and dopamine, all stimulate the vestibular system, causing anxiety. And the locus coeruleus, which is the center in the brain responsible for the vast majority of synthesis of noradrenaline, and the locus coeruleus innervates vestibular nuclei, cerebellum, limbic cortex, hypothalamus, and the hippocampus. All those same areas involved in the neurophysiological model are also involved in stimulation with noradrenaline, and that comes back to the possible medical treatment options later on. And then lastly, if we look at a cognitive behavioral model, it's based on the hypothesis is based on two observations of normal physiology, which is that vestibular stimulation causes a strong physiological response, which includes anxiety, and anxiety, particularly panic, causes a strong physiological response, which includes vestibular symptoms. So one can then imagine a scenario where you get a vicious cycle with hypervigilance for fear and triggers and situations in which you can be expecting to encounter those triggers again in the future. Behavioral conditioning then occurs very much like in Pavlov's dog, which eventually results in an exaggerated rescue response. And the rescue responses would include reaching for something to stabilize the perceived motion, and also avoidance behaviors. And the avoidance results in reciprocal reinforcement of the behavioral pattern. So the end result is basically a fear of the consequence of the symptoms, and also cognitive distortion, including catastrophization, which is basically a belief of the likelihood of the worst perceived outcome being most likely. So if we look at the pathogenesis of PPPD, like I said in the beginning, it involves the precipitants can be a myriad of disorders, initially causing some dizziness or vertigo. You get acute syndromes. Basically, any unilateral vestibular hypertrophy is very common. The diagnoses in red are the particularly common ones. So unilateral vestibular hypertrophy, for example, from a vestibular neuritis, a labyrinthitis, anything like that, can precipitate an acute dizziness syndrome. That'll be a final precipitant for PPPD. Or medical conditions such as traumatic brain injuries, including even really mild injuries, just concussion and whiplash, are described to eventually cause PPPD. Syncopal disorders, stroke, and any bedridden state from any acute illness can be a precipitant. And then if we look at episodic syndromes, vestibular migraine, benign positional paroxysmal vertigo are particularly common, and Meniere's disease as well. Panic attacks, particularly common, and arrhythmias. And then chronic syndromes such as bilateral vestibular hypertrophy, superior semicircular canal dehiscence, and more commonly the medical conditions such as autonomic hypertension and tachycardia, and generalized anxiety disorder are particularly common in precipitating subsequent PPPD. So the patient then undergoes some acute adaptations that, you can imagine a normal physiological response to vertigo or a fear of falling would be to stiffen one's postural control. So that would result in a stiffened stance and gait, moving really cautiously like you're moving on a thin sheet of ice, taking really short strides and using supports as you go. Secondly, the patient shifts the relative weighting of sensory inputs in their mind for spatial orientation and posture control where they start to favor visual and somatosensory cues much more than the vestibular input. And lastly, there's a hypervigilance for self-motion. So these adaptations would normally initially be helpful and would eventually allow the patient to resolve their disorder, but the adaptations are supposed to revert to normal when the precipitating situation resolves or when compensation occurs. However, in patients with neurotic personalities, which neuroses include anxiety and depressive disorders, some people are more predisposed to undergoing a maladaptation, which results in triple PD. So this is where basically the higher cortical functions are unable to regulate those acute adaptations, and that causes a perpetuation of the symptoms in response to normal, naturally occurring motion and visual stimuli. This is a nice slide of sort of summarizing the pathogenesis of triple PD. And if we look more at the maladaptation processes in the center of the diagram, you can see that it starts off basically with an excessive self-monitoring and vigilance, which is thought to be due to hypersensitivity to brief discrepancies between movements planned by the cerebral cortex and actual movements that are achieved by the body and then sent by somatosensory and proprioceptive sensors back up to the brain. So that discrepancy then causes an expectation of unsteadiness, which actually overrides the sensory input coming from the somatosensory and proprioceptive systems. This then leads to some secondary effects as well at the top of the picture up here. So firstly, you can imagine chronically stiffened postural control would result in neck stiffness, can result in a functional gait disorder. A vicious cycle of fear and avoidance can obviously cause some secondary phobic disorders, including agoraphobia. And when we come to the differential diagnosis, there is a little bit of similarity between agoraphobia and triple PD. And then lastly, the increased burden of self-monitoring causing the sort of the mental overload that was described to one of the Tygerberg Hospital doctors by one of their patients as being brain fog, basically in Afrikaans, brain fog, causing exhaustion and fatigue and even sometimes dissociation. So if we look at the clinical presentation, basically the underlying symptom is dizziness. Despite the new sort of titrate paradigm shift in terms of describing dizziness versus vertigo as not being all that reliable these days, and especially in contexts with language barriers and disabilities and stuff like that. Anyway, the most common description of the dizziness in triple PD is a rocking or swaying motion. It's persistent, but it does fluctuate in severity because of situations where there's distraction or exhaustion, and also varying levels of alertness. The symptoms in triple PD are typically exacerbated by provoking factors such as an upright posture, any movement, whether active or passive, in any direction or position. And then lastly, complex or moving visual stimuli, such as the patterned carpet in this hotel that looks like it's straight out of the 1980s, and busy street scenes and traffic intersections and busy restaurants and shops. So in a way, that sort of busy marketplace stimulating vertigo and dizziness and phobic responses is similar and has some overlap to agoraphobia. So when you've got a patient with triple PD, the important things to ask about on the history would obviously be to ask about the details of the precipitating disorder that started it all off. What was the disorder? Is it fully resolved? How is it treated, etc. Then to come to the presenting complaint, obviously the dizziness is important, but then also important to ask, are they getting hypersensitivity to movement or optokinetic visual stimuli? Are they getting anticipatory anxiety in situations where dizziness would cause problems, Like, for example, do they become really anxious if they have to walk upstairs, or walking or driving on a road? Does that cause anticipatory anxiety? And do they get phobic avoidance of those situations? And if so, do those phobias result in social or occupational impairment? There probably are some different subtypes of triple PD, but it's controversial and not yet well defined. And then lastly, there are 3 most commonly comorbid disorders that are associated with triple PD that one should inquire about on a history. And those 3 disorders would be migraine, panic attacks, and generalized anxiety disorder. So if we look at an examination of a patient with triple PD, the posture may be normal in some cases, or they may have an increased body sway. If you do a Romberg test, it again may be normal, but it may also have amplified compensatory movements of the arms. The gait may have a secondary functional disorder with slow and hesitant gait, like walking in a thin sheet of ice. And the gait remains slow even after the patient has gotten going, unlike a Parkinsonian gait, which is only difficulty in initiating the movement and then speeds up. In triple PD, the gait remains slow and hesitant throughout the walk. Then one should add in distraction techniques during the examination. So if you're testing just simple posture, you can write with your finger on the patient's back while they're standing still, and ask them to identify what number you're writing with your finger to distract them. Or while you're doing a test of walking, you can ask them to go in their mind verbally through serial sevens, subtracting 7 from 100 sequentially. And basically, if the posture or gait disorder normalizes with distraction, then this firstly provides evidence of a functional basis of the disorder, as well as also providing the patient with evidence of reversibility of their disease. And that will then become useful in the subsequent rehab of the patient. So if we look at the International Classification of Vestibular Disorders from 2017, the diagnosis requires all 5 criteria to be met. And so if you just go through them, firstly, the dizziness would be fluctuating in severity, lasting normally for hours at a time, and occurring on most days of the month for more than 3 months at least. It'll be exacerbated by upright posture, movement, whether active or passive, in any direction or position, and like we said, the moving or complex visual stimuli. It'll be precipitated by any vestibular disorder, any neurological disorder, any generalized medical condition, or even psychological stress. The symptoms must cause significant stress in the patient, and the symptoms must not be better accounted for by another disorder. So importantly, it's a diagnosis not of exclusion, but rather a diagnosis of inclusion. So you're not making the diagnosis by ruling out all other causes of vertigo, but rather by ruling in the specific symptoms. Secondly, it's a diagnosis based on symptoms alone. Signs that you elicit on the examination of the patient, or features on lab investigations or neuroimaging, may support the diagnosis alone of triple PD, or in combination with other diagnoses. So if a patient gives a history of symptoms of triple PD, then the findings of positive clinical signs or lab results or imaging features of another disorder don't exclude the diagnosis of triple PD, but rather the patient just has both disorders. Unless, of course, the disorder is better able to be accounted for the symptoms by another condition, and that comes back to criterion E in the diagnostic criteria. One should be aware of making some commonly erroneous assumptions, like the patient's obvious psychopathology must surely be the sole cause for the dizziness. Well, that's wrong. Psychotic people do also get other causes for dizziness other than triple PD. They may have another disorder. And the second assumption is that psychopathology cannot be involved in this patient's symptoms because we've now found an obvious organic cause. That also is wrong. The obvious organic cause may have been the original precipitant of triple PD, or they may just be comorbid. So if we look at a natural history of the disease, the precipitants that tend to arise in acute syndromes tend to cause triple PD symptoms that start after the precipitant symptoms fade. There usually is no interval procedure. The triple PD usually follows immediately on after the precipitating symptoms have faded. The conditions, the precipitants in episodic syndromes tend to cause episodes of triple PD symptoms that just become more and more and more persistent until you have the triple PD. And then lastly, the chronic precipitants are a little bit more difficult to diagnose triple PD because they tend to cause an insidious onset of triple PD symptoms over many, many months or years, which makes the diagnosis more difficult, partly just because the patient starts to remember details differently, forget details, and have biases in their description. So if we look at a differential diagnosis for triple PD, firstly, it can just be ongoing symptoms of the precipitating disorder before compensation has occurred. It may be coexisting psychological disorders that account for the anxiety symptoms comorbid with or coexisting with a vestibular disorder. Agoraphobia, like we said, is one possible differential. You know, the fear of the crowded marketplace, and that causes some dizziness and phobic avoidance of situations. From Scott Brown, there's a nice table comparing conversion disorder, malingering, and factitious disorder. And basically conversion disorder, and they're comparing it to chronic subjective dizziness, just because that edition of Scott Brown was published just before the definition of triple PD had come into effect from the International Classification of Vestibular Disorders. So conversion disorder, basically the onset coincides with a major psychosocial stressor where the patient converts their emotional symptoms into physical illness, which is manifested by neurological symptoms. Malingering and factitious disorder both involve lying about a complaint of dizziness, sometimes with other neurological symptoms. And both disorders have inconsistencies when the patient is asked again at a later point, or the symptoms may vary with distraction. In malingering, the motivation is for secondary gain, often monetary gain or work avoidance. And in factitious disorder, the motivation is for personal gain, where the patient wants to be the patient for sympathy kind of reasons. And in factitious disorder, the patients are often allied medical workers and often have repeated presentations at different hospitals. So that's just things to bear in mind when you get almost any sort of functional disorder. When it comes to treatment, the first step in the treatment is to reassure the patient. Don't try and reassure them by listing all the negative tests that exclude organic lesions, because then the patient kind of feels like, well, they're incredibly dizzy and anxious and etc. And you're now telling them that there's nothing wrong with them, or it's all in your head. So rather reassure the patient by telling them that they do have a specific diagnosis. We know about the diagnosis, it's common and it's treatable. The second step is to educate the patient as far as possible as to the mechanism of their symptoms. And then further treatment would be tailored according to the patient's dominant complaint. You know, so we said that the dominant complaint might be anxiety or a gait disorder or dizziness. And there's different aspects of treatment that address the specific complaints that the patient may have. Starting off with psychotherapy, particularly cognitive behavioral therapy, that's well known to psychiatry, is aimed at reducing the fear of falling, anxiety, and avoidance behaviors. It works by gradual exposure first to an internal origin of symptoms that can be simulated by hyperventilation, and then to external origin of symptoms by situational exposures. With cognitive behavioral therapy, however, there's no evidence of long-term benefit. It seems to be beneficial while the patient is in therapy, but less beneficial when therapy ends. Next, there's vestibular balance rehabilitation therapy, VBRT, that basically works on reducing sensitivity to motion. It improves confidence with balance and reduces visual and somatosensory dependence. And basically then facilitates compensation to avoid avoidance, is the catchphrase of the feared situations. Next in line is the physiotherapy that works to desensitize the patient's vestibular symptoms over compensatory movements. And that has shown long-term benefit as long as the exercises are continued. But it's much easier to continue home exercise than it is to continue long-term cognitive behavioral therapy. And lastly, there's medication that aims to tone down the interactions between vestibular, visual, and anxiety systems in the brain to cut that whole vicious cycle. So if we look at the medical treatment, there's selective serotonin reuptake inhibitors and selective noradrenaline serotonin and noradrenaline reuptake inhibitors, which obviously are commonly used in many psychological disorders, including depression and anxiety. But the difference when you're treating triple PD is you should start with a much lower dose on the lower end of the spectrum that one would use for psychiatric disorders, and increase the dose really slowly. Patients with triple PD tend to be particularly susceptible to side effects, specifically nausea and disturbed sleep. The outcomes in medical treatment of triple PD are that about 60% of patients have reduced symptoms within 2 to 3 months. And if so, then treatment should be continued for at least 1 year. But 20% of patients literally cannot tolerate the side effects and end up stopping their own treatment voluntarily. So it's quite a high proportion. If the treatment is poorly tolerated, then one can try another SSRI because even if they've had a complete failure or intolerance of one SSRI, they often do tolerate a second SSRI. And if that one is still poorly tolerated, then you would move on to the SNRIs, which are not first line because the side effects are usually even worse than SSRIs. So that's the sort of the regimen. So which treatment is best, the patient's going to ask. You know, should they go for cognitive behavioral therapy? Should they go for physio or medication? Which one is going to work best? And the trouble is that there's no large-scale randomized controlled trial with long-term follow-up for treatment of any chronic dizziness. And when it comes to triple PD specifically, some of the problems are variations in diagnostic criteria. You know, triple PD only became a diagnostic entity in 2017. So the nomenclature is changing. Some people in long-term studies, cohort studies, are still using diagnostic criteria of chronic subjective dizziness. And, you know, that's not really going to work if you're looking at triple PD. Particularly when you want to be really careful about inclusion and exclusion criteria for a research study. Secondly, there's controversy regarding the optimal dose of medications, the SSRIs and SNRIs for treating triple PD. It's known from anecdotal experience that you need to start with a low dose, but then some people in research trials describe ceiling doses where you're not allowed to go above a certain dosage. But then the complaint is that, well, maybe if you were allowed to go above that dose, maybe the treatment would be more beneficial. So there's a bit of controversy as to what is the optimal dose, what is the safe dose without getting too many side effects. And secondly, dizziness may occur as a side effect of withdrawal of SSRIs, particularly those with longer half-lives. Fluoxetine and paroxetine have long half-lives, and as they start to withdraw, the patient may experience some dizziness symptoms. So that's not necessarily failure of the treatment, that's just a side effect of the treatment. And then, of course, dizziness may also occur independently of underlying triple PD. For example, if you start a trial looking at treatment of triple PD, a patient may still develop another disorder like migrainous vertigo and get dizziness that they won't realize is actually not from the triple PD, perhaps, and is actually from another disorder. So it's quite tricky to know how to design a proper sort of research trial for triple PD that's actually going to be effective. Which is why there's not a lot of long-term follow-up of randomized controlled trials, and all the treatment options are based on cohort studies, short follow-up periods, and small randomized trials. But that's where we're at. Thank you very much. Does anyone have any questions?
Thank you, Simon. That was an excellent presentation, very informative on triple PD. If you have a question, please post on the chat function, or please use the raised hand function, and we will allow you to ask the question. Without further ado, Christine Rogers, I would please like to hand over to you and ask you if you have any comments on this very interesting topic and on Simon's presentation.
Thanks so much for asking me to comment. Simon, that was an excellent presentation. Thank you so much. I thought it was really comprehensive. There's a couple of comments I'd like to make. The first thing is, and you did stress this, but I just want to support what you were saying. This is a definitive diagnosis. This isn't a sort of waste paper basket where if you don't know what's wrong with the patient, you kind of stick them in there. That's the first thing. So there are definite sort of diagnostic criteria, and these are all in the Journal of Vestibular Research, as are updated criteria for virtually all of the vestibular disorders. So that is the first thing. The second thing is, I think that the probably likely the best combination of treatment for recovery of these patients with triple PD is the vestibular rehabilitation therapy as well. Because that's also helpful in addressing secondary disorders like vestibular migraine, for example. So I think the way the research is heading at the moment is that a combination of cognitive behavioral therapy, which we know is treatment of choice for anxiety, plus SSRIs or similar, plus vestibular therapy is absolutely first prize. And with vestibular therapy, we anticipate some level of improvement in terms of how the patient's doing within about 6 weeks. So it's not a sort of prolonged kind of course. Vitamin supplements, well, if patients were at full risk, there's definitely an argument to be made for vitamin D. And certainly when we see patients with recurrent BPPV, for example, we always like to suggest that those levels are checked. And I think the other thing, there's a comment coming up from Feroz about the investigations. Essentially, they're going to show either they're going to reflect the initial triggering event, so you're going to get a picture of unilateral weakness, and there your big differential diagnosis would be a partially compensated vestibular lesion. So they're complaining of things like visual smearing with head movement and so on, and that frequently then morphs into the triple PD. But essentially triple PD is characterized by entirely normal investigations. But I do also agree with Simon. Sometimes patients, you know, they feel kind of moved to sort of impress you with the severity of their symptoms. So you can get a little bit of embellishment on things like the Romberg. But primarily your main issue here is a diagnosis on the case history, and the case history is really important. And I know a lot of you work in extremely pressurized clinics. It's having the time to actually step back and make it really patient-centered and really listen and hear your patients, which is very difficult when you've got people breathing down your neck and another sort of 40 patients sitting on the bench. That really is the key. Virtual reality, I've just seen a comment there. Simon, you might want to comment on that. I've actually just used a form of virtual vestibular rehabilitation therapy in my doctoral degree, and it's every bit as successful as conventional therapy for reducing falls, for example. And this could be the way to go in developing countries, because the whole argument is that you don't need highly skilled either audiologists who specialize in vestibular therapy or physiotherapists or occupational therapists. That there is a future for this in terms of just having an assistant help the patient on and off the device, and then they can manage the therapy on their own. So yeah, there's definitely a future for that, I think. However, you've got to bear in mind that true virtual reality is intensely nauseogenic. So, you know, you do still need overall supervision by somebody with specialized training. So I hope I've just captured some of those comments and questions. And I'm very happy to take any other questions, but an excellent presentation. Thank you.
Thank you very much. I see one of the comments from Dr. Mohammed Feroz is about the role of having a multidisciplinary treatment approach, and that certainly is our approach in Friedrichsruhe in our Dizzy clinic. It's run with Ms. Rogers and the audiologists and the ENTs, and often end up in referral to psychology and psychiatry, vestibular physiotherapy rehab. So certainly a multidisciplinary approach is really important.
Thanks, Christine and Simon, for those comments. We've got a raised hand from Sulaiman Ansar. Sulaiman, would you like to go ahead and ask your question? We've seemed to have lost Sulaiman. Simon, thanks again for your presentation. Christine, thanks a lot for answering the questions as they came up. And if there's no other questions, I'm going to end the meeting soon. I just want to remind everyone of the case presentations this coming Friday at 8:30 GMT +2. And we would like to welcome everyone to that. Sulaiman Ansar, would you like to comment?
Yes, please. Thank you for this nice presentation. My question is, the criteria is 3 months duration. What about those patients who come with the same symptoms, same signs, 1 month duration? Any diagnosis for that? Apart from PPPD?
Yeah, well, thanks very much for the question. It's, I suppose, with any sort of ICD-10 criteria, or it's now going into ICD-11, you've got to draw a line in the sand somewhere. And they've just decided to, because it falls under the umbrella terminology of chronic vertigo, they've made a line in the sand of 3 months. So, of course, a patient may come early in the sort of presentation at only 1 month, and I think one would then just have to be aware of a broader range of differential diagnoses and treat the patient with whatever the symptoms they have, according to the clinical examination and the history, bearing in mind that it might be an early presentation of triple PD, but you can't call it that until it meets the diagnostic criteria. I don't know if Ms. Rogers, do you have anything to add to that?
No, nothing to add to that, but I'm happy to comment on the question from Michael Medina. Says cognitive behavioral therapy and SSRI is also first-line treatment for obsessive compulsive disorder. Is there a link between triple PD and OCD? No. Previous thinking was that in previous formulations, like when it was phobic postural vertigo, for example, the thinking at that time, and that was in the 90s, was that there had to be presence of a psychiatric disorder. And for triple PD, there does not have to be presence of a psychiatric disorder. However, anxiety and depression are very common fellow travelers with triple PD, but that can be on a reactive kind of basis rather than that's kind of who the patient is. When we are doing our case history, we always sort of probe for that a little bit. Does it really kind of bug you when things aren't in the right place and that sort of thing? But that's really just to get more of a perception of who the patient is rather than a diagnostic criterion. So I hope that I've answered that question. There isn't, strictly speaking, a link.
Excellent. Thanks, Simon. Thanks, Christine. I don't see any further raised hands. And I don't see any, there's one more, there's one more question. This is interesting, from Dr. Essa. Is there a pro forma set of questions that assist in doing the history? And especially for doctors who's seeing these patients for the first time and don't deal with dizziness maybe on a daily basis. Simon, Christine, could you maybe help with this?
Yeah, I haven't come across any pro forma set of questions. But just two things to say to that are, firstly, that seeing a new patient with chronic dizziness for the first time, one should set aside a reasonable amount of time because it's going to take a while. And secondly, in terms of useful resources, a very useful website is that International Classification of Vestibular Disorders. If you do a Google search for that, it takes you to a website with really good short video clips of the characteristic clinical features, different types of nystagmus, etc., like that. So it's a really useful website. And if there is any sort of pro forma set of questions, I think you would find it on there, but none that I'm aware of.
Can I just chip in here? I think it basically gets back to that whole triple TA. The timing here is really important. So it's that persistent characteristic of more than 3 months. And often these patients are chronic and they've had this for many years. I think another big key for me is me then and me now. And I think that captures the issue that there might have been triggering event of either some sort of general medical illness, or often at our clinic, it's more likely there's been some sort of previous vestibular mishap that might have been many years ago, but you've got to get that out in terms of, and then how the symptoms have changed. So then the type is important. And then I think the other issue is those triggers. So it's very, very strongly associated with complex visual stimuli. So the supermarket, for instance, is really problematic for patients. That anticipatory anxiety, the maladaptive behavior, those are all really important. The fact that there's no hearing loss. A big thing for me is asking what improves it. And we often are good at asking what makes it worse, but what improves it. And there's two really nice little gems here in terms of the case history. One is that it improves with exercise, which obviously most other forms of vestibular disorder, as soon as you start taking 1 foot off the ground to run or, you know, walk briskly, something like that, it is in itself a controlled fall, and yet they do very well with exercise. The other thing is, if it's culturally appropriate, if your patient does consume alcohol, they often improve after a glass of wine. So I always look for those two things, just that little bit. Now, it is mentioned in the literature, and it's certainly something that I find in my clinical experience that just helps nail it down.
Thanks a lot, Christine.
Thank you very much.
There's one more question, also from Dr. Issa. Is there nystagmus in triple PD? And Simon, Christine, any one of you can answer that. Yes,
so it comes back to, yes, there may be nystagmus, but it's not part of triple PD. A patient with triple PD may have nystagmus if they have a peripheral or central disorder, but triple PD diagnostic criteria are all symptoms. So you make a diagnosis of triple PD on the basis of the symptoms, and they may have nystagmus if they have ongoing residual effects of the precipitating disorder, or if they have any comorbid disorder that causes nystagmus, either central or peripheral, or side effect of medication. Yeah.
Okay.
What is the pathophysiology of triple PD in anemic patients? Not sure. So generalized medical conditions can certainly be one of the precipitating factors to cause triple PD, but specifically anemia, I'm not sure. I think you would have to have really severe anemia to end up causing a dizziness. But certainly it would be an option. And then, yes, yeah, that was answered, that other question.
Thanks, Simon. Thanks, Christine. There's no other raised hands and no further questions. We look forward to seeing everyone on Friday morning at 8:30. And with that, I'll